Hello, my name is Andrew Engle. I and Stephen Embry are family medicine residents at Offutt Air Force Base. Today I will be presenting a case report titled Catamenial Psychosis, an Atypical Cause of Psychosis. My co-author and I have no financial disclosures. Catamenial psychosis is a periodic psychosis that occurs cyclically with the onset of menses, and is itself a subset of menstrual psychosis, of which there are 5 types. These types are differentiated by the timing of symptom onset in relation to menses. Catamenial psychosis is characterized by episodes of psychotic or bipolar symptoms such as mania that occur with the onset of menstrual bleeding. Catamenial psychosis has been rarely described in the medical literature with less than 200 cases. However, experts note that it is likely significantly underrecognized and estimate its incidence to be as high as 1 in 10,000 women in the United States. The fact that menstrual psychosis responds to appropriate hormonal therapy and is poorly responsive to traditional antipsychotic and mood-stabilizing therapies makes prompt recognition and diagnosis important. Menstrual psychosis was first described in 1759, with increasing numbers of cases reported in the German and French literature throughout the 19th century. Diagnostic criteria was proposed by the German psychiatrist Richard von Krafft-Ebing in 1904 and further revised in 1914. During this period, a number of cases were described, and the diagnosis appears to have been well known in the French, German, English, and Japanese medical literature. However, throughout the later half of the 20th century, the diagnosis was made with decreasing frequency, likely due to changes in psychiatric nosology. In 2005, Brockington et al. Revisited the diagnostic criteria and proposed the criteria currently in use. To establish a diagnosis of catamenial psychosis, the following criteria must be met. A patient must present with an acute episode of symptoms of psychosis or mania. The episode must occur in a background of psychiatric normalcy and be brief in duration with a full recovery. Finally, the episodes must be periodic with a clear association with a specific phase of the menstrual cycle. To improve the accuracy in diagnosis, Brockington et al. Proposed the use of a parametric and non-parametric test to improve diagnostic accuracy by proving a statistically significant association with a particular phase of the menstrual cycle. Presented is the case of a 40-year-old female who presented to the emergency department for evaluation of abnormal mental status with confusion, graphic visual and auditory hallucinations, and active suicidal ideation. Her past medical history was significant for bipolar I and numerous other psychiatric diagnoses. Her surgical history was significant for a cesarean section and tubal ligation. She smokes cigarettes and drinks alcohol. Her family history was non-contributory. Her menstrual history was significant for long-standing irregular menses with heavy bleeding. She had a history of numerous similar episodes with auditory hallucinations, impulsivity, and minimal sleep requirements that had been diagnosed as bipolar I. But, despite medical therapy with numerous mood stabilizers and antipsychotics reproduced here, she continued to experience episodic psychosis. In the emergency department, the patient's vitals, initial lab work, and a CT head were unremarkable. She did have evidence of bacteriuria for which she was given antibiotics. Additional laboratory analysis, including a comprehensive metabolic panel, CBC, inflammatory markers, psychotropic medication levels, and drug screening, failed to reveal abnormalities. Neurology and psychiatry were consulted, and an extensive neurologic evaluation was also negative. Throughout the course of the admission, the patient's presenting symptoms improved and a more complete psychiatric evaluation was completed. It was revealed that both the patient and her significant other had noted a recurring pattern where her symptoms worsened with the onset of menses. Furthermore, her symptoms were improved in the past while on combined oral contraceptives and during her prior pregnancy. Based on the temporal relationship of her symptoms with the initiation of her menstrual cycle and failure to improve with standard pharmacotherapy, the presumptive diagnosis of catamenial psychosis was made by the psychiatry team. She was subsequently evaluated by OBGYN, and due to the patient's active tobacco use and migraine history, she was deemed a poor candidate for oral contraceptives, and an intrauterine device was placed. This yielded neither the gynecologic or psychiatric benefits desired, and she subsequently underwent a complete hysterectomy with bilateral oophorectomy, which resulted in approximately 6 months of complete symptom resolution without hallucinations or manic symptoms, followed, unfortunately, by symptom relapse 6 months later. The underlying etiology of catamenial and other menstrual psychoses is hypothesized to be due to an underlying dysfunction of the hypothalamic pituitary ovarian axis involving GnRH, LH, FSH, estrogen, and progesterone. Some authors have proposed that menstrual psychoses share the same underlying pathology as postpartum psychoses, which makes logical sense given both occur during periods of marked hormonal changes. Furthermore, hormonal changes may play a role in the physiology of other psychiatric conditions. This is supported by the improvement in symptoms of schizophrenia in women with estradiol therapy, and the observation that women with bipolar disorder are at a markedly increased risk of recurrence in the postpartum period, which coincides with significant declines in estrogen and progesterone. The onset of catamenial psychosis corresponds with similar decreases of estrogen and progesterone in the menstrual cycle immediately preceding the onset of menses. These observations have particular bearing on this case regarding the patient's improvement of symptoms while on oral contraceptives and during pregnancy, but not following her hysterectomy. This makes sense, as the patient was never treated with pharmacologic suppression of the HPO axis, such as with leuprolide, a direct agonist of the GnRH receptor. This treatment has the most support in the current literature. If the underlying pathophysiology of catamenial psychosis does indeed lie within the HPO axis, surgical interruption and suppression of the axis at the level of the ovaries may not adequately address the site of dysfunction within the axis. Intriguingly, multiple case reports from the first half of the 20th century document attempts to achieve symptom resolution through hysterectomy and oophorectomy with minimal success. This contrasts with several contemporary case reports which report marked and dramatic resolution of symptoms with leuprolide. Our case demonstrates several of the difficulties inherent in establishing the diagnosis of menstrual psychosis. A background of normalcy cannot easily be established in this case, given the patient's 20-year history of psychotic episodes with multiple preceding diagnoses. It remains unclear if these previous diagnoses represent prior misdiagnosis of catamenial psychosis. Additionally, our patient suffered from abnormal uterine bleeding, which introduces a unique challenge when attempting to apply Brockington's proposed statistical test to confirm the diagnosis. Given the reported number of cases are significantly lower than the estimated prevalence in the literature, this begs the question, what is the true prevalence of catamenial psychosis in the United States? In conclusion, catamenial psychosis is a subset of menstrual psychosis where the onset of symptoms coincides with the onset of menses. A careful menstrual history should be completed in female patients of reproductive age, as prompt recognition may provide significant benefit to patients, as treatment is hormonal rather than psychiatric. This is especially important to family physicians as they are uniquely engaged in the primary care of women of reproductive age and are well positioned to recognize cases. These are my references. Thank you.